be the 7-star pharmacist plus, 7 plus. Because even if you say, if they get their medicines, and they often say, somebody's about to kill me, the pharmacist is there to look at adverse events. Pharmacovigilance comes into play. So the pharmacist is there. In good health and in sickness, we are there. We are talking about giving life, supporting life. The pharmacist is there. So, would we agree to pledge as pharmacists to say that wherever and whenever medicines, including vaccines, are being used, there should be involvement of a pharmacist? And to also add, anyone who uses medicines and has never benefited from the direct input of a pharmacist has been shortchanged. Or should we say they're lying? So currently, FIP, as I said earlier on, has worked hard to support pharmacy education in Africa through the UniTwin program. And this is in line with workforce development goals so that pharmacists are adequately trained to meet their mandate as primary healthcare practitioners and be counted whenever medicines and vaccines are used and or discussed. But if you agree that we should be there whenever medicines are being discussed or being used, then what is happening with the very low number of pharmacists who are available in our countries? And how do we confront the fact that we are not being equitable in availing ourselves and our services to citizens of our countries in Africa? We tend to practice mostly in urban areas, leaving huge swaths in rural areas and the countryside without any pharmacist or pharmacy whatsoever. We often refuse to do community service in the rural areas. Or I know in my neighboring country, for you to be registered, community service requires you to go and work in the rural areas. But we always complain. And yet we say we're the experts. We are the 7-star pharmacists. And people expect us to do the best. So, distinguished ladies and gentlemen, colleagues and friends, our rights and privileges as pharmacists, they come with responsibilities. And that privilege is based on our training. So, we are to do this, we have to be accessible and available and try as much as we can to have equitable distribution of pharmacy personnel to other levels. We have a huge responsibility, and our swan song should not be rescue the perishing, care for the dying. No, not at all. It should be we have a charge to keep alive. We are charging, our role is to keep people alive and not the dying as our primary role. So we also have to empower our patients so that they are alive through various modes of primary health care. So our profession is a healing profession, and it involves the whole human body. There are several ways in which we can make immediate impact. And I will just list a few of those. And so I'm aware some of you are involved in these various areas. But of course, we can't be expected to be doing everything. Can I please have the next slide? These are the simple ones, which came with the COVID, primary health care, hand washing. Since time immemorial, we've always been washing our hands, but let's do it right to ensure that disease is not spread. I know we've been talking about even during cholera and all other diseases, and we still want to strengthen this and do it right. How are people using their disinfectants? Sanitizer use and the quality of the sanitizers. Here, the Zambian pharmacists produced a video on CPA with regard to production of sanitizers. And the use of face masks. In Zimbabwe, we produced a video on how to use the masks properly. Quite often, I've seen people wearing them upside down, downside up, inside out, and the quality of these face masks left a lot to be desired. And during this COVID pandemic, as an association, we actually communicated or were collaborated with the regulators so that the quality of sanitizers and the quality of these products, the PPEs, are of good quality. So we motivated our regulator to promulgate legislation on the quality of sanitizers and the quality of face masks and other PPEs. So they had to come up with legislation. So as pharmacists, these products were being distributed left, right, and center. But the quality was always questionable. Even with the WHO guidelines, because everyone in the streets, they thought they can do it. But we tell them the pharmacists can always do it better. Advocacy. We want to support and initiate promulgation of appropriate national policies, legislation, and regulations. So I'm actually impressed that we've got members of parliament, and let's support them when they're campaigning, because they will be representing our views as pharmacists in parliament and in government. Next slide, please. All right. I just decided to make this slide very busy. I did that on purpose. These are the pharmacy services, which are expected of pharmacists. As I said, pharmacy will not die, but it has to be transformed according to what is happening around us. And we are well trained, and our training and continuous professional development, which is the CPDs, are making us be able to do this. I'm not actually expecting you to read all this screen, because I've got another page with the same sort of busy. All I'm trying to say is pharmacists are very busy people. They've got a lot of roles to play. This 7-star plus pharmacist is involved in pharmaceutical care, adherence counseling, rational medicine use, taking leadership in fight against NCDs and communicable diseases, leadership in neglected tropical diseases, the fight against COVID-19, antimicrobial stewardship, healthcare financing, pharmacoeconomics, smoking cessation, air pollution, and someone was talking about respiratory disorders, the previous presenter. And as pharmacists, do we think we have a role to play in air pollution? There was a presentation from FIP on air pollution, which was done by GRIP. And I hope as pharmaceutical associations, we'll keep on educating our members on this area. Can I please have the next slide? That's why I said these two slides are very busy. I made sure that they are busy to show that there's so much busyness which we can be involved in. Someone did a presentation on HIV, ST, asthma, anticoagulant, and cardiovascular clinics, pharmacogenomics, someone is a member of the Drugs and Therapeutics Committee. So there's a lot of things which you can do. Maternal, adolescent, and child care, risk perception and assessment, market dynamics, and I like the presentation from the president yesterday. We're involved in pharmacy, and as a society, I was quite impressed with trying to come up with manufacturing, with the pharmacists being in the lead. I also picked a few notes from the presentation, because we are also trying to do retail pharmacy scope for importation of medicines for the retail pharmacies in Zimbabwe, and was battling. And I was actually motivated to see that PSK is doing even bigger things. PrEP and PEP, pharmacists can be involved. So there was a presentation as well on that. Self-care and patient empowerment. Then this, which is written number 6 there, is actually number 25. If I add up from the previous page, it's number 25. I got to a point where it was the end of thinking capacity, because the list is endless. The list is endless. We can do so much as pharmacists, but sometimes we leave ourselves in a small corner and we cry like crybabies. And yet we are so much empowered, and our associations are there to empower us, which is why I say whatever we do as an association, we want to bring it to all pharmacists, whether they are our members or not. They are pharmacists, and there's an impact on how the profession is looked at, whether they are members or not. So I want to also encourage our pharmacists to join and be members. So I just made sure that this slide was very busy, to show that it's a very busy profession. So this is arguably a very tall list, and no one is expected to do everything at the same time or all the time. Rather, by task shifting and by developing and ensuring availability of adequately qualified support staff, pharmacists may be able to move away from products towards patient-focused care, which is medicine-centered, and that is beneficial to global health. The road ahead looks extremely exciting, and we're on it together. COVID-19 pandemic has opened new doors for innovation. As I get to the end, towards the end of my presentation, what I would like to share, and we want to always talk about it and remind each other. I know you are already doing a lot of this, what I'm talking about, but revision makes perfect. A strong pharmaceutical society with powerful visibility nationally, regionally, and internationally is what we would want. The membership should stand strongly behind the leadership to increase the power and assertiveness of the leadership. We elected them, and let's support them. The motto is one PSK. FIP is talking about one FIP, and in this instance, I said one PSK, everyone. Actively, they should also actively work with policymakers and regulators, work with government and schools of pharmacy to make education for pharmacy relevant, take part in negotiations with government in terms of remuneration for pharmacists and reimbursements, maintain active and widely distributed pharmaceutical communication, and ensure frequent appearance on TV, on media, and be part of the House of Assembly of Parliament. I just added that one last night. So ladies and gentlemen, some of this, I've been motivated and mentored by a great colleague who is a pharmacist from Ghana. He has been a good friend and has been a good mentor. So this one I quote from him. He would say at the end of his talks, so in true pharmacy fashion, may I end this keynote address by committing each and every one of us to God's greatest keeping and protection. May we all look for the active pharmaceutical ingredients of perfect science, which imbues us with patient-focused and medicine-centered practice. And may we blend this with the lubricants of advocacy, communication, and constant assertive engagement with government and public and other health workers. And may the final product of this formulation be packaged, labeled, and delivered with enthusiasm and passion and placed on the shelves of the heart of each and every Kenyan pharmacist, so that in years to come, we shall say, we changed our profession, our country, and our world for the good. May God richly bless us all. Thank you. as I say on my last slide, thank you, asante sana, obrigado, siabonga, tatenda is the Shona from where I come from, bonjour. Congratulations on organizing such a great conference. Thank you, ladies and gentlemen. Thank you, the convener, Mr. President. Thank you.
Thank you so much, Madam Vice President. And all I can say is God is good all the time. I want to give Sylvia, Dr. Sylvia, a few minutes to say a few words before I introduce the next speaker. So, Dr. Sylvia.
Other than to say amen, Madam Jocelyn, that was a fantastic presentation. Thank you very much. It's great just to hear the call to action for us to step up as pharmacists into being 7+ star type of pharmacists. Thank you for that great inspiration. I wanted just to make a small comment to challenge us and to challenge specifically our leadership. Our PSK President, Dr. Lee Mashagu, our PSK CEO, Dr. Daniela Mnene, thank you for putting this together alongside with the convener for this particular conference. My challenge to us as an organization, Pharmaceutical Society of Kenya, the body that it is, strong as it is, and for us as members, all you pharmacists, the one action that I'm going to ask, what are you going to do to ensure that we actualize this huge investment when it comes to us as pharmacists stepping up in driving patient education, stepping up in being critical stakeholders in diagnosis of asthma, stepping up in participating in capacity building and guidelines dissemination and owning those guidelines, because treatment of patients and guidelines is not a precipice of someone else. We are at the center of it as well, and we've always been a bit at the back end. So my call to action is, what are we going to do in that particular space beyond just ensuring that the patient get the quality of medicine that they deserve? So Mr. President, Dr. Lee Mashagu and Madam CEO, Dr. Munene, my challenge and call to action is, what will we do as PSK to get from the table with companies like AstraZeneca, which I'm representing today, to ensure we get through a sponsorship agreement that will enable members of PSK who are community pharmacists be able to invest and step up the level of patient care at the pharmacy level. Because as organizations, we can't come to individuals. We prefer that we come through our organizations as an organized body, but it will also be dependent on the leadership and the rate of agility that we're going to step in for the Africa Pumua initiative. So my ask is for us, and for us as a leadership and for the members, to step up into the space when it comes to community pharmacy, to step up into the space of real-world evidence and data generation, policy and advocacy. We are doing a lot of work with the Ministry of Health, but we need the pharmacists to be at the center of it all, instead of just it being left to the Respiratory Society of Kenya, which should be part and parcel of. So I think the days of waiting for things to happen are gone. Pharmacists, we must be at the driver's seat. And that for me is just to challenge our leadership to organize us and ensure that initiatives like the Africa Pumua initiative that you can see up here actually benefits patients in a structured, sustainable, beneficial manner, because the health of the patient is determined by how well we step up to our roles. So really, thank you very much for this amazing opportunity, and to the speaker that has just finished, really, hats off to you. That was extremely inspiring. I'm walking away feeling 9-star, to be very honest. I feel very much 9-star. But thank you also to the convener and the organizers and Dr. Anisa as well for giving me the 2 minutes just to make that comment. And I'm hoping Dr. Munene and Dr. Mashogu that we will follow this up and share with the members what PSK is doing as far as this initiative is concerned. All right.
Thank you, Dr. Sylvia. Those were a lot of breaths, but thank you very much. The presenter talked about fluorescent condoms, and I saw many people very excited about that. So I'll tell you a little story. When I was practicing pharmacy back in the day, and a lady came up to me and said, do you sell extra large fluorescent condoms? And I said, yes. And then I was waiting for her to say something, and then she just waited on the side. So I said, "Madam, is there something I can help you with?" She says, "No, I'm just waiting for the person who comes to buy them." Great. So our next presentation is going to be, now we're going to the presentations by individual pharmacists. And our next presentation is by Dr. Veronica Kihugi. It's Safeguarding Blood Transfusion in Developing Countries, Insights from a Cross-Sectional Observational Study at a Secondary Health Facility in Kenya. Dr. Veronica, please, you have been allotted 20 minutes. Please stick to your time, and if you can do it in less, we'll give you a bonus point. Thank you.
Thank you very much. Hello, everyone. I am Veronica Njambi Kihugi. I'm from the School of Pharmacy in Jomo Kenyatta University of Agriculture and Technology. And my presentation is on safeguarding blood transfusion. And these are insights that were derived from an observational study at Thika Level 5 Hospital in Kenya. Next slide, please. Blood transfusion is the transfer of blood or blood components from a donor into the bloodstream of a recipient. So blood transfusion is done to save life by replacing blood that has been lost through bleeding or bone marrow depression. The World Health Organization reports that about 12 million donations of blood are done globally every year. Blood is still, however, a very rare commodity in our hospitals and health setups. Indications for blood transfusion include anemia, congestive heart failure, acute sickle cell disease, hemophilia, cancer, and acute blood loss. There has to be a match in the cross-matching test of the donor and recipient sample for transfusion to actually take place. These cross-matching tests are done in the blood transfusion lab. Blood should be given to the right patient at the right time, in the right way, and for the right reasons to avoid blood wastage. Transfusion-related risks may arise from human errors or sometimes due to blood factors. Human errors account for most of the transfusion-related risks, and this leads to morbidity and mortality. These include hemolytic transfusion reactions, transfusion-transmitted infections, transfusion of incorrect blood products, among other transfusion-related risks. So if compliance to guidelines and proper monitoring of the transfusion process is done, then these morbidities are preventable. In our situation here in Kenya, we have World Health Organization transfusion guidelines and the Kenya National Transfusion Guidelines, which should inform us on the transfusion process. There are no standard transfusion protocols being used at Thika Level 5 Hospital, and this was a reason for conducting this research. So to our problem statement, poor practice in transfusion causes morbidity and mortality. Human errors, as I have said, can be prevented, and this study was done to identify such errors and find a way to use blood as a rare commodity in the right way. The justification for this research: Thika Level 5 Hospital is a busy health institution. It serves even neighboring counties, and it has a blood transfusion satellite. Management of the transfusion process in Thika Level 5 has not been harmonized, and this raises concern over blood handling, wastage, and the eventual risks that may occur to the patient. Remnants of initial blood after transfusion process had previously been seen hanging in the wards, and it is unsure whether these remnants were discarded or reused. The aim of the study was to fill gaps towards offering safe, efficient, and professional blood transfusion services. Next slide, please. The objectives for this study were to evaluate the efficiency of blood transfusion practices. So we were able to assess the indications for blood transfusion at Thika Level 5 Hospital, the time lapse between the time when health personnel actually ordered blood to the time the patient actually received the blood for the transfusion, compliance to transfusion policies by health personnel, and blood handling and blood wastage. The study was conducted at Thika Level 5 Hospital between January to March this year. It was a descriptive observational study that was conducted at the lab. Blood was followed up from the transfusion labs to the wards where transfusion was actually taking place. The study population were the patients who are undergoing blood transfusion and the health personnel who are involved in the transfusion process. All patients who participated in blood transfusion were involved in the study, and only transfusions that occurred in the theater were excluded. Our data collection tool was a WHO-derived observational checklist. This checklist was based on the transfusion guidelines in the World Health Organization document, and it contains guidelines on how transfusion should be done. This includes issues like blood should be well cross-matched before being given to the patient. Consent should always be sought from the patient before the transfusion process. And consent also involves giving information as to why the transfusion is being done and the risks that may arise. Pre-transfusion assessment that should be done by assessment of vitals. Assessment of vitals at 15 minutes into the transfusion process. This is done since most transfusion-related risks begin to occur at 15 minutes into the transfusion. Records should be kept before, during, and after the transfusion process, and there should be infection prevention and control protocols being used for blood bag discarding and even discarding any unused blood. The variables that were assessed included patient assessment, duration of the transfusion, blood handling, record keeping, and transfusion complications. Prior ethical approval was sought from Thika Level 5 Ethical Review Board before the study commenced. So our results. The first slide of the results shows the flowchart of how blood samples were handled in the study period. In total, 202 blood group cross-matching tests were done in the 1 month period when we were able to collect our data. Out of these, about 56 were returned back to the lab or released or uncollected if health personnel did not come to get blood after they had ordered it. For those that remained, we were able to study most of them and record them in our data collection tool. And out of this, we were able to observe 51 blood transfusion events. Next slide, please. For the patients that were involved in the blood transfusion process, the age group between 18 to 35 were mostly involved, and most of them were females. The age group over 70 years were the least involved in the blood transfusion process. The gynecology ward had most of the transfusion cases, followed by the maternity ward. I think this is why most of the patients who undertook the blood transfusion were females. Next slide, please. The time lapse, as you can see on the first graph on the left, the time lapse between the time when blood was requested to when patients actually received it was 1 day. Some patients, however, had to wait for several days to get blood. As you can see, some patients had to wait for about 7 days or 8 days due to issues like maybe they had no donors to donate blood for them and other issues at the transfusion lab. The main indication for blood transfusion was symptomatic anemia at 53.7%. Other indications for blood transfusion were blood loss, ectopic pregnancy, cancer, and other transfusions took place at the theaters. In most cases, blood was not fully used up. And the remnants were sometimes left hanging in the wards for long periods. Consent was rarely sought. Consent was only sought in about 17% of the cases, and some patients had no idea why they were receiving blood. Some of the patients would complain that they think they're healthy, they don't understand why they have to undertake the blood transfusion process. Next slide, please. Post-transfusion assessment was barely done. As you can see on the pie chart on the left, post-transfusion assessment was only carried out in 39% of the cases, just as assessment at 15 minutes was ignored. In most cases, the health personnel, who are mostly interns, would start the transfusion process and leave, so that nurses would come later on after the transfusion was done to remove the cannula when the process was over, and this was done without paying much attention to the patient. Records were done in only 41 of the cases, while in 55 of the cases, there were improper or no records at all. This was despite having a transfusion sheet. Every health personnel would pick blood from the lab, was given the blood in the carrier box, together with a transfusion sheet that should contain the details of the patient, assessment at each point, and any transfusion reactions that may occur. But most of the time, these records were filled halfway or not even filled at all. Transfusion reactions occurred in 27% of the patients. They included fever, irritation, skin rash, palpitations, and none of these reactions were reported back to the lab, since even the records were sometimes not fully filled. Next slide, please. We observed non-compliance to transfusion guidelines, especially in pre-transfusion assessment, assessment of vitals at 15 minutes into the transfusion process, giving patients information, post-transfusion assessment, and even blood bag handling at the end of the transfusion process. This was contributed to by lack of proper guidelines, non-functional equipment at the wards. This is mostly equipment which were to be used in assessment of vitals, and understaffing, where most of the transfusion work was left for the interns. As pharmacists and healthcare workers, blood transfusion should be an important aspect to us. Blood is therapy, just like the medicines that we dispense. We should thus be at the front line to ensure this blood transfusion process is actually done well. Blood transfusion has continually emerged as a major therapy for some of the diseases in our current generation. And thus, as pharmacists, we should be keen to look at how patients are actually receiving blood as a therapy to their illnesses. Pharmacists should also play a major role in the transfusion committees in our hospitals. Every transfusion committee should have a pharmacist, and the pharmacist should have a say on how the process is actually done. Patients should not just receive blood because it is a formality. We can also do research to inform on this very, very crucial process. We recommend that transfusion committees are set up and managed well in all our hospitals to oversee transfusion matters. This involves blood donation, blood storage, blood procurement, blood handling in the lab, and also the transfusion process itself. Local protocols and standard operating procedures that are aligned with transfusion guidelines should be set up at our hospitals to oversee the transfusion process. Continuous medical education for health workers about transfusion matters and blood as a therapy should be done regularly in our hospitals. As I conclude, I would like to thank God for His strength during the time that we were conducting this research. I would like to thank the Pharmaceutical Society of Kenya for organizing this great conference and allowing us to present our findings here. I would like to thank the Thika Level 5 Hospital Administration because they allowed us to conduct this research in the transfusion lab and at the wards. I would also like to thank the supervisors for this research, who are Dr. Godfrey Mayoka from the School of Pharmacy in JKUAT, and Dr. Bernardine Lusweti, who is a pediatrician at Thika Level 5 Hospital. And at the end of it all, I would like to thank you all for listening to this presentation. Let us take up the role of ensuring that blood as a rare commodity is handled in the right way. Thank you very much. I now give it back to the moderator for questions.
Thank you, Dr. Veronica. All the questions should be put on the Q&A chat, and then Dr. Veronica can answer them from there. The other day, when Veronica was conducting her study at Thika level 5, one of the doctors asked her, "So Veronica, why are there different blood groups?" And Veronica was stumped for a bit, and she said, And the doctor said to her, "Before you answer that, let me tell you, it's because mosquitoes have a choice of flavor." Thank you for your presentation. Our next speaker is Dr. Johnson Anyona, and he will be talking about strengthening health supply chain performance by enhancing a data use culture for decision making to foster local solutions and continuous improvement. Wow, that's a mouthful. Enjoy. 20 minutes, Dr. Johnson Anyona.
Thank you. Good morning, ladies and gentlemen. My name is Dr. Johnson Anyona. I'm a supply chain analyst and pharmacist working for InSupply Health, and I'm joined by my colleague who will introduce herself.
Good morning. I'm Dr. Faith Ndeto, a sub-county pharmacist in Nairobi County. Welcome.
Okay, welcome to our presentation. We shall be presenting today on strengthening health supply chain performance by enhancing a data use culture to foster local solutions and continuous improvement through the impact team approach. Next slide, please. So I'll give a bit of background about InSupply Health. So we are a health advisory firm headquartered in Nairobi, Kenya, with an office in Dar es Salaam as well. We are affiliated to JSI Research and Training Institute, and we provide clients with customized guidance on supply chain management and design. We offer an array of supply chain services offerings, but specialize particularly in co-creating solutions with our beneficiaries and clients to ensure that they are adapted to the context and used to optimize performance. Next slide. So a bit of background on impact teams. So what are impact teams? Impact teams is a people-centered approach to strengthening supply chain. So the impact teams have a shared goal of improving product availability and a collective responsibility to identify and implement solutions to supply chain problems. So the impact teams are made up of people across functions and disciplines who are trained to set targets and interpret key supply chain indicators. I remember on Tuesday, there's a presenter who was asking which are good supply chain indicators to use. So later on, we are going to find out some good indicators to track your supply chain performance. Then these people are also encouraged to follow a problem-solving process, and they are empowered to use their data to make operational and strategic decisions with the ultimate goal of continually improving the performance of their supply chain. So in summary, the impact teams are a data review team who are trained, encouraged, and empowered to use data to make decisions to improve their supply chain. Next slide. So JSI and InSupply have implemented and evolved impact teams to build supply chain capacity, foster a data use and continuous improvement culture for supply chain in 10 countries and across different supply chains. As you can see on the slide, we've worked with vaccines programs, FP programs, TB, HIV, malaria, MCH, etc. In 10 countries and across different supply chains and levels of the health system. So in each country, the approach has been adapted to the local context and specific supply chain needs. Next slide. So in Kenya specifically, InSupply has implemented impact teams in 17 counties overall. Initially, on phase 1 of the project, that was between 2016 and 2018, we worked in 10 counties, focusing on family planning and vaccine supply chain and working at the county level. A mixed method study found that significant improvements in stock status and stock out rates compared to counties which were not implementing. So, however, while impact teams were successful in improving supply chain performance, the teams were heavily dependent on partner support, and when support ended, the impact teams stopped meeting regularly and performance went backwards. Next slide. So now in phase 2 of the impact team project, our focus was on sustaining improved performance by institutionalizing the impact teams and processes. We also recognized the importance of context. So our goal was to build on the previous impact team experience and develop adaptable models that could be used across different contexts, that could facilitate scaling and enable institutionalization so that this could be a sustainable approach. We wanted to make sure that anyone could implement the impact teams and see the same success, not just JSI or InSupply. So in phase 2, we chose to work with 9 counties, 2 from our regional work, 2 completely new but relatively mainstream, and 4 from the marginalized hard-to-reach counties, which my colleague Dr. Suleiman alluded to earlier in the week, to help us understand issues across different contexts. Next slide. We chose to implement a combined approach of human-centered design and adaptive learning. We knew that big challenges such as institutionalization, motivation, and sustainability could only be addressed together with the impact team members, and human-centered design was perfectly suited to help us do that. And adaptive learning, because we knew as we worked across very different contexts, we would need to keep iterating on the approach, the tools, and solutions that we were using. Next slide. So our HCD research yielded some important insights. First, the optimal level to implement was at an operational level. Remember I said in the first phase we implemented at county level, that is at CHMT level, but we realized that the optimal level to implement was at sub-county level, where you still have managers empowered to make operational decisions, but they are more connected to frontline health workers, the primary healthcare workers that we are talking about. So impact teams use a root cause analysis and a problem-solving approach, which requires knowledge of operational issues, and the county level was too far removed. So secondly, the data we know that data is the backbone of impact team performance, but data visibility alone was not enough. So data needed to be visualized so that it's easy to interpret and translate into actions. And thirdly, was that having an influential leader to support the team and believe in what they are achieving is critical for change. Next slide. So we then began our adaptive learning approach. So we routinely collect data on impact team processes, such as meeting frequency and whether or not key impact team approaches are followed. We also collect data on challenges or successes from the impact teams, implementation, and the supply chain outcome indicators. So each month we review a topic of interest. We begin to prioritize challenges and develop program adjustments to implement or test. So some of these adaptations have been what we call revolutionary changes, where our approach significantly changes. We'll talk about one example on the next slide, but others are more evolutionary, meaning that they enhance a current process or adapt in smaller ways to address challenges. So in both cases, this process has allowed us to move away from traditional monitoring and evaluation to better tailor interventions to contexts and in real time. Next slide. Next slide, please. Just go to the next slide, please. Yes, that one, thank you. So after 2 rounds of adaptive learning, we realized that the system archetypes we had created, so initially we had categorized the impact teams, the sub-county impact teams as we had assessed the maturity as being either basic, intermediate, or advanced. But we realized that those system archetypes were not helpful in identifying what implementation support the teams needed to evolve and get to the next level, which was our intention. So we went back to our HCD insights and translated the findings into a different framework for looking at our teams. So we called them role profiles. That was our revolutionary change. We've also adopted new tools and processes to support this new approach, including new action planning tools and new ways to collect and visualize data. These have been more evolutionary changes. Next slide. So as part of this program shift, we've identified 7 role profiles critical to the success of impact teams and their associated knowledge, skills, and competencies. So this helped us implement more effectively by assessing each profile based on the key technical competencies. We can target capacity building efforts to build a team with a holistic skill set for creating meaningful change. So on the screen, you can see the 7 role profiles that we came up with, which we are saying are critical for the impact teams to perform effectively. So for each team, you need someone who is good at organizing. So this is the person who will handle the logistics, note-taking, documenting action plans, and follow up with people assigned with the action plans to make sure that they actually happen. You also need a problem solver. So this is the person who will push the team towards practical and actionable next steps and challenge the usual approach of tackling problems. You need also a data whiz person. In most cases, this is the health records information officer in the sub-counties. So this is the person who understands the indicators, can extract the data, can prepare it in a way that the teams understand and can digest. Then you need someone good at supply chain. So in most cases, we've noticed this is where the pharmacists usually fall. These are the person who has a deep understanding of the supply chain processes and can offer solutions to supply chain problems. So those first 4 are the ones we refer to as core members of these teams. And then the remaining 3, that is an influential person, the person who can link us to resources, and the overall leader are the one we refer to as enabling support members. So for each meeting, for each data review meeting, you have to have the first 4 people, the core members, so that the impact team can be effective. But at the same time, you also need the last 3 who provide enabling support. They don't need necessarily to attend the data review meetings, but their support is more impactful behind the scenes. All right, next slide, please. So our HCD and adaptive learning sessions have yielded other changes. So initially we were tracking the supply chain indicators using an Excel-based spreadsheet, but we've now developed an indicator tracking tool dashboard, which we shall be sharing the link shortly, where you can be able, anybody can access it to check on the performance of whichever county, sub-county, facility that they're interested in. So another key change that we developed is an IT portal. So the portal is basically a decision support tool, which helps counties and implementers associate team processes with outputs to see which processes serve as levers for more effective performance. So the portal has now the learning packages which the teams can build the capacity on, the role profile assessments to assess their competencies, process indicators on the impact team approach, other IT tools which can be useful, and even gaming, which my colleague Laura talked about, just to reinforce learning. So we have some games there on supply chain management. Next slide. So at this point, I would like to invite my colleague, Dr. Faith, to share her experience from her sub-county. Welcome, Doc.
Okay. Thank you very much, Dr. Anyona. So just carrying on from what Anyona has been talking about, I represent Ruaraka Roysambu sub-county in Nairobi. So as part of the impact team, we were able to do a role profile assessment that involved going through a series of 3 questions per competence and 3 competencies per role, and coming up with a consensus on whether our impact team had a person or people with the desired skills for each role and to what level on a scale of 1 to 5. We were also able to put faces to the personas and assess their availability to the team. So that's checking whether they were never available, or sometimes available, or always available. So in my sub-county, our sub-county MOH happens to be our resource reader and also our Lucy leader. Then the pharmacist who's me is organizing auto and supply chain Sam, and our HRIO is our data with Diana. So based on this assessment, then now we were able to see where we needed to probably put in some more effort and probably engage the learning packages that Dr. Anyona talked about. So based on these results, we realized that we had strong skills in terms of organizing, but we had some gaps in supply chain, in the supply chain area, because in the team, it's just me who does supply chain. We have a person who assists with at the depot, but we needed to put in more effort in terms of that. Next slide. So I'm just looking at some of the results and some of the achievements that we've been able to do. Like Anyona mentioned, somebody had been asking about what supply chain indicators to monitor. So based from on the dashboard, then now we are able to look at indicators like reporting rate. So looking at completeness or timeliness of our reports. Then now once you're able to achieve good reporting rates and completeness of your data, then now you can move ahead and look at quality of the data. So one, the first picture shows the reporting rates, which is from our sub-county, so you can see consistent change or improvement over time. Then the next one is about absolute differences. It may look obvious, but we realize that facilities, because you don't have pharmacy staff in all the facilities, so you realize facilities struggle with having with looking at the absolute differences. That's looking at the ending balance for a certain commodity a certain month and the beginning balance the following month. They should tally, but in most cases they don't tally. So if you look at what Mvita has been able to achieve for combined oral contraceptive pills, you can see a constant decline in that absolute difference. Ideally, it's supposed to be 0. Then the other things that we've been able to monitor are stock out rates and figuring out how then are we able to influence decisions and push if it's DRH or DVI for resupply or redistribute the stocks that are available in the facilities. Then also stating months of stock, so avoiding overstocking in facilities that leads to expiries. Then looking at things like for vaccines, we've been able to look at coverage, which is a service indicator, but is also reliant on commodity data. And then looking at things like wastage rates, which tell us what is being consumed in the facilities and whether we are getting any missed opportunities. So just looking at these pictures shows you the improvements that the impact teams have been able to do, and not just in Nairobi, but across in the counties where impact teams have been implemented. So this, the site where you can access this information for your county has been posted on the chart. So maybe you can just have a look and see how your county is performing. Next slide. Next slide, please. So what next then for the impact teams? So like I said, all the impact teams have been able to do a role assessment. So based on the role assessment, then now you can be able to access learning packages from the sites that JSI links us to in supply. So then you can you can see what to improve for your team. So like my team, we need to relook at the learning packages for the supply chain and see how we can be able to improve. So understand learners' motivation, applications to help improve impact team and performance. So we also want to move away from just looking at FP and vaccines and have many other commodities, TB, ART, malaria, incorporated in the dashboard, so that then as a team, you're able to follow up on all those indicators. So this will be based on what does a sub-county or county require to monitor. So just tailor making the web page so that then you're able to use this information to make decisions. Next slide. So just in conclusion is just to say we need to move beyond just having data in KHIS, which is what happens in public sector. We have a lot of data in KHIS, but we do not use it for making informed decisions. So we need to move away from that and just engage the various teams, having multidisciplinary teams at county, sub-county facility levels, where you can be able to assess your data on a monthly basis and come up with improvement plans for you. So I'd like to thank my colleagues, pharmacists who are here, who've been implementing impact teams across board. Most of them are the ones who lead the teams. Our implementing partners in supply, JSI for the technical support and the learning opportunities, just so that to enhance this journey of data use culture for improved supply chain performance. So thank you very much for your time.
Thank you for that presentation. Very informative. The other day, there was a job opening for these young pharmacists and others for these impact teams. So they were interviewing for an impact team, and they said, they called 3 people for their interview. One was an accountant, the other one was a farm tech, and the third was a data analyst. So the first guy went in, the accountant went in, and they asked him, what's 2 times 2 by 3 or 2x3? So the accountant says, oh, that's easy. That's 6. So they said, okay, fine. They went and they said, okay, next person to interview. So when the next person went, it was the farm tech, and they said, what's 2x3? So the farm tech says, that's easy. You take 2 3 times a day. So the third one, they went for the interview, was a data analyst, and they asked him, asked her, what's 2x3? So the guy, the lady looks around. She says, is this for the impact study? He says, yes. Is it a good job? Is it yes? Is there a good long-term contract? I said, yes. Says, then the question is not what's 2x3. The answer is not, it's what you want to make it. Great. The next presenter is someone who needs little or no introduction. She was one of the first pharmacists that I met when I started my profession. And she has put in a great amount of time, energy, and resource into the pharmacy profession. And if I was to give a standing ovation for one of the pharmacists, this would be the person. Professor Jennifer Orwa. She's going to be talking about rapid response mechanism for research evidence, a case study of Kemri's knowledge transformation platform. Professor Orwa.
Thank you very much, Annie, for that introduction. I am always happy to join PSK, particularly in the annual conference. And I'm glad my presentation has actually been produced very well by Anyona and team. Pharmacists are busy, and we really have lots and lots of data. We are actually streaming in a lot of data, but it is not being packaged to reach the users so that they can have informed decisions. So my presentation on rapid response mechanisms for research evidence, we are trying to develop a tool where we can quickly be able to translate the research information that we have with us. So allow me to start by saying that the fact that knowledge creation and knowledge management and knowledge translation are critical elements for pharmacists to optimize patient health outcomes in their response to emerging healthcare dynamics. So as an introduction, I will say that knowledge translation normally aims to enhance evidence-informed decision making so that we can improve healthcare practice and provide better outcomes for our patients. But we have all along noticed that linking health research evidence to action, although it is critical for our response to contemporary health challenges, we find in our